It is a timely topic of today's webinar and today's healthcare environment. Evidence-based practice. Evidence-based practice is a conscious, rigorous application of best evidences to the practice. When we say that, there are three prong components to evidence-based practice. First of all, in order to have evidence-based practice, we need to have best research evidence. And further, need to have clinical expertise who would adopt the research results and apply and utilize for patient needs and patient values. When these three components are complete, then it becomes the policies to the practice for evidence-based practice. So evidence-based practice is not just research, not just practice, not just patient feedback, but all these three things involved. And it is interdisciplinary, as you can see. Research evidences are created in collaboration with academics, universities, and clinicians. So clinicians are involved, academics are involved, and patients are involved. So it is interdisciplinary in nature. There are a lot of benefits and barriers. Benefits is just many. There are very few mentioned here. Ultimately, evidence-based practice is to improve patient outcomes in terms of safety, quality, healthcare cost, and healthcare delivery quality improvement. And it is a gold standard for healthcare delivery process. And it is an integral part of magnet status process. Magnet status process is a process of quality improvement certification for the hospitals who adopt the evidence-based practice in United States. Barriers of evidence-based practice, practical, conceptual, and it may become a standard of cookbook if we do not apply or update. Practical barriers may come from all those three areas of evidence-based practice creation. First of all, availability of best evidence. Next practical issue is, are we disseminating the evidence? Next issue is, are we utilizing the evidence? Next barrier is, are we evaluating the evidence? All this involves logistic details or practical details, and all these stages can have barriers. It can be knowledge barriers or practice barriers. Conceptual. Conceptual means any hospitals or the clinical settings or the academic settings, are they ready conceptually? Policy-based. Conceptualization for evidence-based practice, is it present? So all these, I can go on for the barriers. There are multiple barriers for evidence-based practice, but benefits are many. Agency for Healthcare Research Quality Improvement series found out the value of translational research products through the health system panel. What did they find out? They say there is a lot of gap. There are numerous research is being conducted, and there is huge sum of money, and the cost is designated to research via funding, via support, via means of research. However, very few research results end up in practice. So, first of all, evidence. Are there best evidence? Not all the research conducted are best evidences. So, do we have best evidences for the translational research? Need for strategies to overcome barriers. As we saw, there are many barriers. Do we have strategies? Implementing evidence-based practice is a challenge and it is a change. And we all need to adopt that. Are we ready? Need to distill and communicate actionable evidence. We may have many evidences. They may be statistically significant. Are they coherent with the clinical cognition? Need for providing most timely and current evidences. What we say right now, 5 years evidences in academic settings. We do not allow students to use for any supporting evidences more than 5 years. What does it mean? Our policies, procedures are changed every 5 years. Clinical settings changes dynamically. Therefore, evidences need to be current. Anything more than 15 years or even 10 years, evidence is considered as expired evidence. So what are the sources for evidence-based practice? Sources for evidence-based practice begins with the synthesis of evidence. So the researchers conduct research and they disseminate research, and we need to utilize research. In order to utilize, we need to first of all synthesize evidence based on the problem. That is the basic tenet of translational research. The first step of any research is synthesis of what is known. So translational research also, the first foundational step includes synthesis of evidences, what is known already on the problem. That includes systematic reviews, meta-analysis, integrative reviews, meta-summaries, meta-synthesis. This is the first step for translational research, aggregating the evidences under a problem, under the purpose, under a question, for the purpose of evaluating, synthesizing, and application of research findings. Evidence-based practice and translation research are two different concepts. Evidence-based practice is application of best evidences for quality care, whereas translational research is a research method of evaluating evidences for the utilization of evidence-based practice. So they both are two different concepts, two different ideas, and they follow two different theories and models and methods. Strength of evidences vary. As we know, research evidences are based on the quality of the studies. So strength of evidence means how strong the evidence or how near the evidence that we can apply to the practice. Accordingly, strongest evidence currently, strongest because research also changes. Currently, strongest evidence is meta-analysis. We will see in detail today about meta-analysis because that is a foundational step for the translational research. Integrative reviews, experimental studies. Weakest evidences are descriptive surveys, qualitative studies, correlational studies, quasi-experimental studies. This is one way of qualifying the strength of evidence. Strength of evidence is a continuum across the studies, depending on their methods. So what we saw in the previous slide, it is given figuratively here. Translational research is the topic for today. Evidence-based practice is the outcome. Translation of research is the means to get to evidence-based practice. Translational research is a bridge between science and practice. So bench science to bed science. So translation research is a major component which will improve or increase or adopt evidence-based practice. In order for us to have an evidence-based practice, we need to have translational research. And it is an interdisciplinary research method. Translational research involves interdisciplinary research method. And it is a collaborative research method, and it is an evaluative research method, and it always focuses on best evidences put into evaluation and applied into practice, converted into policies and guidelines, then end up in evidence-based practice. When we say translational research, there are a lot of concepts associated with it. First of all, we need to have best research. In order to have translational research, we need to have research. Research is a systematic investigation of a phenomenon to answer research questions or hypotheses. Implementation science. Implementation science is implementation science, also called translational science.
Ma'am, sorry to disturb you. Can you put it in the slide mode, ma'am?
It doesn't work slide mode. I tried that.
Okay.
Let me try one more time, okay?
Yes, please, ma'am.
Oh, you got it? Okay.
Now it's coming, ma'am. It's okay.
Okay. All right. Implementation science also, thank you. Implementation science also called a translational science. Implementation of interventions. So a researcher takes the results of interventional studies and synthesize them and develop another study to evaluate these findings into clinical setting. This is called translational science. Dissemination. Dissemination is another concept, very important concept associated with translational research, is that the researcher once conducted the study, the researcher has the responsibility to disseminate to the targeted audience. For example, if a study is in a critical care, the researcher has conducted in critical care, and the researcher has an obligated responsibility to publish that study results into the critical care arena and area. So that is called dissemination. Not just critical care academics, critical care practice, clinicians, expertise, and healthcare professionals, etc. That is called dissemination. Dissemination is the pivotal point for translational research. Next, after dissemination, what happens? Comparative effectiveness research takes place. See, translational research has multiple stages. Multiple stages. This is the next stage, comparative effectiveness research. This is the evaluative research, taking the best evidences from the experimental studies and evaluate them upon a solution to a problem, with associating with alternative therapies, assessing the risk benefit, and with the significance attribution to what are the side effects. For example, if it is a drug study, in this time, it is a very essential phase of research where the researchers take the results and translate into comparative effectiveness research. In this research method, they study the risk, benefit, side effects of those drugs. And also they study, is there any alternate drugs that can be used for this disease condition? Further, they study what are the cost effectiveness of this particular intervention compared to what is present. So all these areas, these are the few areas I'm pointing out. There are multiple variables they involve in comparing a new experiment with the current standard practice. And they compare and evaluate the effectiveness of that new intervention. Next is knowledge translation. Knowledge translation is the next stage. Once we know the effectiveness and we have evaluated the effectiveness of the findings of multiple studies, then we need to translate that we need to synthesize them, first of all. Globally, research studies are conducted upon the problem every second, every minute. There are published research results are coming into publications. Now, at this stage, knowledge translation, in this stage, the researcher takes those previous findings from previous studies upon a purpose and the problem and synthesize them, and then disseminate those syntheses and for ethically sound application. Knowledge, getting the knowledge transfer. This is another, this phase of the translational research has an ethical consideration. Knowledge transfer. Who owns the knowledge? Who conducted the study? Who is the primary institution or the author? Who holds the copyright for that publication? Who has those results? Therefore, how we can disseminate or transfer those results to the companies or the institution who would put together for a policy and procedure for practice. Just because somebody has conducted the experiment and has a significant result, that does not mean that is transferable information. So there is whole arena of research studies upon evaluation of those results in multiple stages, as we have seen, and they arrive to knowledge transfer. When they arrive to knowledge transfer, institutions, accredited institutions like AHRQ, IOM, Institution of Medicine, CDC, Cochrane Reviews, all these are some of the professional institutions upon that expertise. They hold the authority to synthesize and develop policies and procedures upon the protocol. So knowledge transfer not only takes the ethical arena, but also legal arena, and then the safety practice protocol and guidelines. Evidence-based practice, as we have seen, it is a conscientious and judicious use of current best evidence in conjunction with clinical expertise, patient values to guide the healthcare decisions. So ultimate outcome of translation research is a evidence-based practice. And it is developed through continuous process, as I have narrated right now. I have narrated few stages and phases of translational research. There are numerous stages of translational research. Once the research has been conducted, there are multiple research after that to get into evidence-based practice. And it is a continuous process. Those phases and stages are called translational research phases. Further, ultimately, any evidence which reaches to the policy and dissemination only can be implemented. So there is a policy dissemination and implementation research is also another stage, a final stage of research, where the evidences become policies, procedures, guidelines. We all know we have multiple discipline expertise are there. We do have guidelines for each expertise and the problem address guidelines. For example, diabetic management guidelines, self-management care guidelines, pressure ulcer prevention protocol, infection control protocol, bed harder. All these are some of the examples of fall prevention protocol, suicide prevention protocol. All these are, how did they come? They came through translational research and translated into evidence-based practice protocol. There are numerous protocols. Finally, it reaches to policy and dissemination and becomes protocol. Once it becomes a protocol, then it is authorized according to the purpose of the clinical need. So in translational research, as I said, it is from the basic science. It is a bridge between basic science to the population science. So basic science is one prism and population science is another end of the continuum of research process. Basic science involves a laboratory studies. As you know, it involves a strict protocol. It does not provide context information, but it is very objective, and it has a detective approach. It is a logistic study, and it involves experimental study, none other than the experimental, tightly controlled, randomized controlled trial. And it is tightly controlled in the laboratory setting. It has its own purpose and merits, but basic science is not, the purpose is not for clinical use. It has a broad application. It is not for application, but for knowledge. So what do? Now we need to convert that knowledge into a practically applicable knowledge. So what do? Next, we have to do a clinical studies. NIH define clinical studies as it is a patient-oriented research. For example, mechanism, studying about the mechanism of disease. For example, right now, let's take COVID-19. A clinical study might involve natural history of COVID-19, which involves incidences, prevalences, onset, signs and symptoms, complications, duration, and treatment. Then next is the treatment and complications, therapeutic interventions. What are the drugs can be used? For example, in the beginning of this COVID-19, there was a lot of buzz and talk around hydroxychloroquine. Was it tested then? No. It was therapeutically intervened. And further, we identified the drug or a few effective drugs for COVID-19. But it took a stages of interventional studies. Next, clinical trials. In clinical trials, studies are on the patients. Take an intervention, apply on the patients who are suffering with the disease conditions, and have an experimental group and control group. Usually it is randomized controlled trial. Development of new technology for the treatment, and then further epidemiological and behavioral studies. For example, epidemiological study means incidences and prevalences of any disease condition in a community, in the public, involves epidemiological study. Next is behavioral study, how people respond to this kind of conditions or any disease condition or any situation, any problem. How do they respond? For example, HIV. Towards HIV, what are the behavioral studies? They focused on psychosocial effect of patients who were affected in HIV. There were a plethora of studies in the beginning of HIV era. Same way, now in COVID-19, behavioral studies, the social scientists, all of them, psychosocial scientists, psychologists, educationalists, and sociologists, all are focusing on how is this COVID-19 is causing stigma, social isolation, how it is affecting mental health. All these areas are behavioral studies, how people react or respond to the disease condition or interventions. Next, outcome research. Outcome research involves mixed methods, and they are evaluative in nature, evaluation of outcome of any conditions or services. Translational research, it is evolving science, it is emerging science, and it is adopted by healthcare discipline widely. And various academic settings and various disciplines involves translational research. Without translational research, there is no evidence-based practice. NIH offered description of translational research. What it entails to translational research? There are two areas of translation. One, research generated in laboratory setting, which is a bench science. Second area is translation concerns research aimed to enhance the adoption of best practice in the community. So one side is bench science, another side is population health research studies. So those are the two areas involved in everything in between called translational science. Significance of translational research is multifaceted, and it is a balance factor between the bench science and the population science, and it involves private, health institutions, public health institutions, governmental institutions, voluntary institutions, and it involves interdisciplinary collaboration to do translational research. And there is gap in all these stages of translational research concepts. There can be a gap in the medical practice if the evidences are not communicated, which is present right now. There is a huge gap between evidences and practice. Currently, what they say, evidence, once it comes, it goes to, not all the evidences goes to practice. If at all they end up in practice, it takes about 15 to 20 years, 5 years ago. Now it is 10 to 15 years currently. That is too huge. Evidence can become expired. That's a gap. That's a predominant gap. It is not published, it's not disseminated, it's not translated. Translational research is a pivotal point for evidence-based practice, which is lacking. So as you can see, translational research is positioned in between basic research and clinical research. So there can be gap in between this. Translational research is the one which bridges the gap. As you can see, in basic research, a disease condition can be studied in the laboratory with a sample, human sample, or animals. It can be studied in animals. Next, that can be translated into clinical research. Now, is there a connection between this basic and clinical? Not always. There is a gap. And then once clinical research has been conducted, is it translated into practice? Not all the research, clinical research, end up in translation. So translation, then after translation, it is looped back to basic research for further research. This is the continuum of translational research. Translation research involves, it starts from basic research, patient-oriented research, it ends up in populational research. Now, basic research method is strictly randomized controlled trial, laboratory study. And patient-oriented research has multiple methods. Involves randomized controlled trial, quasi-experimental design, evaluation designs, mixed method. All these can come in patient-oriented research. And population-based research is community participatory research method, action-oriented research method, and it involves multiple research methods involving quantitative, qualitative, mixed method, evaluative outcome methods. Those are two huge concepts embedded within population-based research. Phases of translational research. NIH has given us a definitive IOM, Institute of Medicine has given us, and NIH has adopted it, definitive phases of translational research. First phase, T0 is a basic science research. It begins with the basic science. And then next is clinical trial. Clinical trial, phase 1, usually involves volunteers. After animal studies maybe basic animal studies, then volunteer human beings are recruited and tested the results of those interventions. Here what they study is, are there any side effects of that intervention? Next phases 2 and 3 in clinical trials are called T3. In this T3, they study the efficacy of the treatment. Is this treatment effective? Is this treatment is going to cure the disease? Is this treatment is less risk involved? So efficacy, what is the cost effectiveness? What is the risk effectiveness? Risk and benefit analysis is done in these 2 phases. Next is clinical trials. Now, once we know it has minimal risk, this intervention has minimal risk, and it involves quality care, and it involves patient safety, and it involves community wellness and welfare. Therefore, it can be, it prevents the disease and it promotes well-being. Therefore, this intervention is very effective. Then it goes to the next phase of clinical trials. Now, clinical trials in which the interventions are applied to the people, those who are suffering with those disease conditions, real patients in a real scenario, clinical trials are conducted. And in this phase, translation occurs. This is the phase that translation occurs. Translational research methods are employed here. Evaluations, research methods are employed here. Strictly adherent to the protocol and guidelines, the research is conducted. There are multiple international, globally studies are conducted currently on COVID-19. They are at the phase of 4 clinical trials right now. Next is population level outcomes research, which is T5, translation to community. So once we know it is good for the patients and it is curing the patients and it is healthy, effective for cost and safety and quality care, then it is made into policies and procedures. Government legislations occur here at this stage, and it is implemented in the larger population setting, which is nationally, regionally, nationally, globally. This is phase 5. So therefore, translational phases oscillates from, it proceeds from bench to bedside, and from the bedside, again, it goes back to bench for further research. So there are models for translational research. Initially, in 2003, Rogers' seminal work, Diffusion of Innovation model was adopted for translational research. Next, in that innovation translational model, the communication of the evidence takes the pivotal role. Synthesis of evidence, communication of the evidence is the huge gap present at that time and even now. So therefore, first of all, characteristics of evidence-based practice determined, then communication process between users of evidence-based practice and social system and rate and extent of adoption. So adoption. All this involves heavily synthesis and communication of evidences in the model of Rogers. Translational research involves interdisciplinary research team, which involves, first of all, there should be a thinker, a big picture thinker, and skilled communicator. Once ideas are developed in the head, and there we need a communicator. This communicator take the idea and communicate to the strategically to the stakeholders. Next, method, a scientist who is well-versed or expertise in translational research. So we need method expertise. Next, domain scholar. Translational research is an interdisciplinary research. For example, COVID-19. Let's take COVID-19. And we are in translational stage right now. So in the translational research, we need all the studies conducted within the COVID, and we need an idea of interventions, and we need a skilled communicator regionally, nationally, and globally. For example, WHO serve as international communicator. So it involves WHO, it involves nations, it involves regions. You can see larger picture of translational research. Next is within those organizations, or for that COVID-19, we need domain scholars, expertise in COVID-19, research scientists. So expertise in infection control, expertise in disease prevention, expertise in health promotion, expertise in bench science, expertise in translational science, etc. We need a team of people in domain as a domain scholar. Next, we need innovators, technologists, innovators, how to implement these study findings into practice. We need innovators, expert implementer, and then we need a bridger. We need like business people. You know, in business, there will be idea in one place and the utilizer consumer another place. There will be a bridger in between. So likewise, here in translational research, research is one side, consumers are other side, and the bridger expertise are needed. We need business people to associate with the stakeholders. That's why we have CNOs, CEOs in healthcare settings who knows business, okay? Then multimodal disseminators. So the translational research does not just involve one researcher or team of researchers, but it involves multi-levels, multifaceted team, interdisciplinary team to do the translational research. So we have translational scientists and scientist team. Interdisciplinary partnership is so essential, as you can see, to enforce translational research. Healthcare practitioners, government agencies, legal agencies, and individuals, private organizations, and translational research scientists, non-governmental agencies. Translational research team should be associated with all this. And I would add another component to this. If I develop this model, patient and community, population as at the large should be intervened or involved in the translational research here. Technology is a huge piece coming in to serve our huge need for translational research right now. Data mining is one of them. It is an emerging concept in the research area of translational research. Data mining is used to aggregate, synthesize data in order to do the translational research with best evidences. Aggregate the best evidences, analyze the best evidences, and aggregate global evidences, aggregate regional evidences are done by data mining. Big data is a huge technological advantage we have right now. We have big data through electronic records, electronic data files, electronic data archives are available right now. We are in the post-information era. So therefore, we have huge data available, and those data can be used for, through the big data analysis, we can use it for translational research. As you can see, currently these organizations are adopting, there is one TransSmart data, and that is being used by NIH, many academics in United States, and government institutions and drug institutions, pharmaceutical, etc., uses big data for translational research. Translational clinical data warehousing is another technology archiving clinical data which is used for translational research. Models and methods of translational research for evidence-based practice. As we all know, and we are aware of this model, this is predominantly used in translational research area, Iowa model of evidence-based practice. In this, there are so much details within these models, and majority of us know this model. While it is in the PowerPoint, I'm going to just highlight what is important in this model. There are two areas. Knowledge is one, and practice, problem-based practice is one. Yeah. So first of all, you identify the gap. Is there a gap in the knowledge or gap in the practice? Identify that. And if there is there is knowledge, there is evidence, but there is a gap in the practice, then you synthesize the knowledge. That is the first step for translation research. Synthesize knowledge. Once you have synthesized knowledge, then communicate, disseminate the knowledge for develop a team. As I have shown you, the translational research team, develop a translational research team to convert the knowledge into translatable knowledge. Once it is translatable knowledge, then disseminate the knowledge for research utilization. Once research utilization has been done, then it is evaluated by patient values to become evidence-based practice guidelines. So this is a flow diagram, but it is not a linear form of flow diagram. It is a continuum, and it is a cyclical event, and it is conditional, and it is also open for innovation. Next model is Steckler model. In Steckler model, we have evidence. In this model, we assume there are enough evidences. So we prepare the evidences. Next, we validate the evidences. First of all, preparation, synthesis of evidence. For any translational research, synthesis of evidence is the foundational stage or an important stage of translational research, preparation of evidence. Next is validation of evidence, assessing the quality of the evidence. Is this evidence can be applicable? Validating the evidence, internal, external validity of the evidences are synthesized. Next, comparative evaluation. As we have seen earlier, comparative evaluative studies are conducted in phase 3. Then next, the evidences are found effective, then it is ready for application to the community. And in the community, we again evaluate and we go back again to preparation. Again, it is not a linear model. It is a cyclical event. As I said, enough about the synthesis of evidence is the basic tenet of translational research. Synthesis of evidence involves multiple, and they are systematic review, meta-analysis, integrative review, meta-summary, meta-synthesis. Systematic review involves quantitative and outcome study synthesis. Meta-analysis involves statistical analysis of quantitative studies. Integrative review involves quantitative, outcome, and qualitative studies synthesis. Meta-summary involves summarizing qualitative studies. Meta-synthesis involves original quantitative studies and qualitative studies and meta-summaries. With that being said, next few slides I have for explaining each one of them. But I would like to focus on, for translational research, majority of the times, what do we use is a meta-analysis. Meta-analysis is the most frequently used synthesis evidence for translational research. So what is meta-analysis? Statistically pool the results of previous randomized controlled trial quantitative studies. And it allows applications of scientific evidence upon scientific criteria to the practical problem. Results of meta-analysis is more specific, and it involves effect size estimation and evaluation. Therefore, it is applicable to the practice. So meta-analysis stands as the first evidence or the highest evidence form of translational research synthesis. Okay, systematic reviews involves quantitative studies that has next level of evidence which can be used for translational research. For any research, we need purpose, we need hypothesis, we need inclusion-exclusion criteria to select the studies and conduct extensive literature search of all sources and develop questionnaire, contact authors to gather further data, critique the studies, individual study become your subject within integrative review or systematic review or meta-analysis. Analyze and interpret data and report the review. And that involves the synthesis of evidence. So Cochrane Review is a website you can visit in your free time. Considering the time, I'm just going to introduce this website to you. You can find a lot of resources regarding integrative review, meta-analysis, meta-summaries, etc. Significance of systematic review in translational research. It is a synthesis of existing finding, which is the first step for translational research. It helps us to understand what is present, and it helps us to understand what is not present about the problem. What is the research gap? What is the significance of the problem? So it helps us to understand what has been studied, what is known, and what is unknown. Therefore, we can proceed to what is known, take the known to put it into practice, translate into science. So systematic review is the first stage, or meta-analysis. Systematic review and meta-analysis is the first stage for translational research. It has multiple stages. As you can see here, we have discussed this. Next, in systematic review and meta-analysis, quality is very important. How the evidence become translatable to the practice, only the quality determines whether it is translatable or not. Not all the synthesized research becomes effective to put it into practice. So method effectiveness. We have to assess each study for internal, external validity, reliability of the measurements, and interpretation of the report. For example, levels of significance. What is the effect size? Is the effect size is enough to apply? What is the effect size of intervention? What is the bias built within the study? What are the levels of significance? How much significant this study is? So all these quality assessment need to be made before sending it to translational research. So systematic review can be reported in the PRISMA checklist. And PRISMA checklist is a gold standard for how to report a systematic review. Next, I would like to spend some time on meta-analysis, which is the pivotal role, which is the pivotal point for translational research. Synthesis of previous studies. What type of studies? Randomized controlled trial. And how do we synthesize? Are we synthesizing narrative details or data? We are synthesizing data. We consider each study as a subject and take the data from the subject and analyze those data upon a common question and then come up with the results for application of the finding. So every research, a single research should undergo analysis, meta-analysis. Therefore, it becomes translatable knowledge. So this is a crucial phase for translational research. So the purpose is to identify statistical significance of the study, effect and magnitude of the study significance, and risk and benefit analysis of the study, and subgroup analysis can be done with meta-analysis. Therefore, we get precise results globally, not just in one nation. In meta-analysis, we can include studies globally, and we can do subgroup analysis upon the conditions and criteria, come up with the precise results which are so pure that we can apply into practice, which will have highest external validity, that we can make it as a translatable evidence for translational research. Advantages, as I have said, it has statistical power. It has a confirmatory data analysis because the researchers have done analysis, and the meta-analysis is the next stage of confirmatory analysis. Therefore, data analysis is so accurate, and it has internal validity higher and external validity higher. And it can be applied to population, not just to the subjects, but to the population, because it involves region, it involves nation, it involves global data. Therefore, it can be applied to population. Disadvantages, it is laborious, and in order to conduct an accurate meta-analysis, it's a teamwork, it involves multiple experts, it involves cost and time. And it has heterogeneity of study population. Effect size of each study vary, and therefore there is a gap. Meta-analysis steps. Again, in meta-analysis, we have a purpose, and we have to do a search of literature, and those literature are limited to randomized controlled trial, but not limited to region or nation. It is globally selected upon the effect size and criteria. In the inclusion criteria and exclusion criteria, we add the studies and collect the data from the studies, analyze the data, and then we verify the data check, quality check, and then report the data. These are the stages of meta-analysis. The research question is the first stage. What type of research question should be for meta-analysis? It should be an experimental research question, which involves PICO, population, intervention, comparison, and scientific specific outcome. As I know, we may have PhD students, multiple master students or PhD students and their advisors in this forum. We encourage students to have all these components in their research question. The best research question will have population, intervention, comparison, and specific outcome. Other things like setting, and again, other criteria are there for the research question. 6 steps of meta-analysis. First, literature search. Select inclusion criteria upon internal and external validity of the study. The study should have higher internal validity and external validity. Internal validity involves accuracy of study findings. highest level of significance. And then external validity involves translatable knowledge, applicable knowledge to the population. Calculate effect size, we'll see in a minute. Do basic meta-analysis, do advanced analysis, report the results. With this one slide, I'm going to explain to you what is the method of meta-analysis. First, literature search includes same question, have a question, pick out question, and select the studies which addresses this question. Same question should be addressed in the research studies. And the method should be randomized controlled trial. And the population and subjects vary. Articles and authors should be included in meta-analysis because we'll be contacting authors to confirm and to get the permission for the copyright, etc. And also to get the unpublished data. Not all the studies data are present within the publication. Publications are usually biased. As we can see, I have shown you some bias we will discuss in the other component. So we need to have unpublished data. So in order to have unpublished data, we need to contact the researchers. File drawer analysis. File drawer analysis is analysis to control for publication bias. If I may say publication has a bias, it is a concrete evidence. Publications usually publishes currently 7 times higher they publish significant findings of the study. Publications focus on studies which have significant findings. Even in PhD studies, we approve studies which have significant findings majority of the times. Any finding is a finding, but publication only involves significant findings. So we need file drawer analysis to control for unpublished data, insignificant findings, or outliers, etc. Then that method is Cartwright-Hayden method can be used. Inclusion criteria concerns of bias. For example, in a single study, there may be history bias, maturation bias, testing effect, and Hawthorne effect, instrument effect, and measurement effect, etc. So internal validity has to be ascertained before selecting the study by the meta-analysis researcher, translational research. Next, external validity. And sample size is a major one. Effect size is another important aspect of considering bias. Quality affects the variances, effect size of studies. How effective the research intervention is to the outcome. How variables are connected, associated. What is the strength of association? How effective the intervention compared to control group is the quality affecting variance need to be assessed. Exclusion bias need to be also addressed. When you exclude study, like publication bias, are we excluding the studies which does not have significant findings? We have to think about that. Transparent in criteria. As a meta-analysis for translational research, we need to be transparent. How did we select this study? Classify the subgroup, groups and subgroups. For example, region varies. A city may vary from region, region from vary from nation, nation will vary from nation to nation, global policies and protocols will vary. So subgroup analysis need to be made and the sampling need to be addressing subgroups. Effect size. Effect size calculation is the next stage. Each study, selected study, we need to do the effect size. Effect size is how effective the intervention to the outcome. How much strength the intervention is associated with outcome. How directly the intervention made difference in the outcome is the effect size. It is calculated by many methods. Cohen-D method is the most common method used in meta-analysis. But we can use Pearson R or even R ratio for meta-analysis effect size calculation. So we need to be using effect size calculation. Next, basic data analysis. There are 2 models of meta-analysis. Fixed effect model and random effect model. Fixed effect model means, remember we said effect size? The effect size is the strength of association between the intervention to outcome, direct association. The effect size, how effective is the intervention to the outcome. Now in these two models, they vary. In fixed effect model, the translational researcher assume that effect size is common across the studies, which you and me know, which is unknowable and impractical, and it always varies from study to study, place to place, geographical distribution, researcher to research. We know that. Therefore, fixed effect model is very rarely or very few researchers use that. Next model is random effect model. In random effect model, the researcher assumes that the effect size varies across the studies. It is random, and which is the logical science, I would say. So random effect model is used, and it can be applied to population. Therefore, it is used majority of the time, and there are methods within how to do random effect model, which is for another day topic. But just know there are two models which are used for translational research meta-analysis. Random effect model is used widely, and because it has most application among the both models. Next is do advanced data analysis for meta-analysis and write the report. So risk of publication bias, as I have already mentioned, publication bias is present and it exists. We need to control for that. How do we control? There is a statistical analysis called file drawer analysis. This analysis count for publication bias. Rosenthal fail-safe N is a method to control for publication bias. And also we need to use funnel plot and Vivia and Wood's method to address this concept. Next, write the report as per Rosenthal fail-safe N method. Let me quickly go through. We talked about effect size. We talked about file drawer publication bias, and it is a result section of a meta-analysis. As you can see here, it is an example of a result section of a meta-analysis, which is represented in a table format with a forest plot. What you see in the right side is a forest plot, and what you see here is the intervention. So in the left-hand side, you have subgroup of the study, meta-analysis, multiple studies, and then you have interventional group here with the mean and comparison group mean here. So effect sizes, interventional mean minus comparison group mean divided by standard deviation. That is the effect size. So that being said, the effect size is explained here in this forest plot. Let's see that. So the weight means how each study weighted for the outcome of this meta-analysis, for the summary of meta-analysis. You can see 100% weight. Among them, individual studies distribute, and higher the number, higher the weightage to the meta-analysis. And then next you see 95% confidence interval, random. In this meta-analysis, they have used random effect size. So effect size are between these numbers, and this is the average summary. If you see in this forest plot, you can see intervention favoring to the left side, favoring to the right side. If you see in the top one, and you can see if you see these, the squares, some are small, some are big. The bigger the square, the higher the weightage the study has. You can see the higher the weightage, smaller the square, least weightage the study has to the meta-analysis. Okay, not to the practice, but to the meta-analysis. But that is the criteria how this can be appraised for the practice, for the translational research. What you see diamond is the summary of the effect. What you see the line is, it is a no effect line. So when the point is at the no effect line, that study has no significance to the practice. When the dot is above from the line, beyond the line, towards the intervention, that study has significance to the practice. So in a simple way, I have explained how this meta-analysis is done and how this reporting is done for translational research. Rosenthal, Harvard University, has published a reporting standard, gold standard. As we said, systematic review has PRISMA checklist. For meta-analysis, we have Rosenthal, Harvard University publication for meta-analytic review report need to be followed. I have a sample here. Due to considering time, I'm just informing there are samples. You can go look in the Harvard University sites, Cochrane review, AHRQ website. You can find a lot of meta-analysis. And recommendation for meta-analysis, it is a teamwork, and we need to agree. It is a team agreement should be there in selection and rationale for selection and documentation of the meta-analysis. And conventional meta-analysis may not be always possible, but we need to be amicable for what is practical. So sometimes statistical significance may not be applicable for practicality. So we have to see both statistical and clinical significance. Meta-analysis team should have always a biostatistician. Many of us know to do statistics. However, we need to have a biostatistician team to guide us. It is an expertise analysis, multi-level, multifaceted, controlled analysis in meta-analysis and for translational research. Therefore, we need biostatistician and experts. Quality control need to be done for meta-analysis. Once meta-analysis is done, we have two scales, grade approach and GEDART scale, which we can use to assess, evaluate the meta-analysis to see whether that meta-analysis can be applied to the practice. Statistical heterogeneity should be addressed. For example, let me quickly go to that plot. This is very important concept. Heterogeneity is a very important concept in meta-analysis. For example, here you see, although this bottom, it is what we consider is that study is not significantly contributing to meta-analysis. It's not significant for practice. However, the lines which crosses here, all these studies have a heterogeneity. That means maybe higher sample size may move the point to the insignificant side, or maybe to the other side. So it has heterogeneity. All that lines which crossed to the favoring control group has a heterogeneity. Not necessarily, it is not just significant right now, but it can become significant later in later situations. So heterogeneity assessment is so important. There are statistical heterogeneity assessment for meta-analysis, for translational research need to be followed. Publication bias sensitivity analysis. There are two methods, network meta-analysis and Bayesian methods. Now, these two methods need to be done by the statistical experts. We need expert guidance from statisticians for this particular analysis for controlling. So this is another example of meta-analysis you can find in Cochrane review. This is adapted from clinical neurology, neurosurgery. So in conclusion, translational research first step is synthesis of evidence. Meta-analysis is a predominant synthesis of evidence in translational research. So first point is discovery, and which is a database synthesis. We need to be collect from the peer-reviewed database. Next is evidence summary. So example would be Cochrane collaboration, evidence summary, which consists of systematic review, meta-analysis, etc. And then translation into guidelines, national guidelines clearinghouse by AHRQ, Agency for Healthcare Research Quality. Agency is responsible for translation into guidelines, integration into practice, next level, AHRQ and the regulatory parties, health insurances, and policymakers, government legislation, all involved at that level, evaluation process and outcome, National Quality Measures Clearinghouse, HRQ, involved in this aspect. That is the nutshell in conclusion. So, translation research is very essential portion of research activities, and it is the bridging the gap between, it is the research process which bridges gap between bench science to population science, which is very essential. In order to do translational science, we need interdisciplinary team, interdisciplinary expertise, and also it involves a huge team, and it is globally population applicable. And the foundation process of translational research is evidence synthesis. And that evidence synthesis, particularly for translational, is meta-analysis. And the outcome of translational research is evidence-based practice. Thank you for the opportunity.